Good morning, good afternoon, good evening, everyone, and welcome to this webinar, Advancing Radiation Safety in Medicine. Today, I'll briefly present IOMP's role, the key areas of focus in ionizing radiation medical exposure, and the importance of collecting data related to frequency, distribution, and trends of radiation usage in medical diagnostics and treatments. This will only be a 10-minute introduction to set the scene, and then I'll give the floor to our distinguished speaker, Dr. Peter Thomas, to present key findings from the UNSCEAR 2020-2021 report and UNSCEAR's activities and plans. Okay, so I'll now present IOMP's role in enhancing radiation safety across medical practices globally. The IOMP plays an important role in promoting radiation safety across medical practices by setting international standards, by providing education and training, and also by promoting research to improve radiation safety. So IOMP's role in setting international standards, we have official relations with WHO, MOUs, agreements with scientific organizations, and excellent relationship with the agency, the International Atomic Energy Agency, IUPAP, and other relevant professional and scientific organizations. IOMP collaborates with those organizations to develop guidelines and standards for medical radiation protection. Education and training, we are organizing webinars and other events, and we are also currently preparing 2 workshops, one in the field of imaging and the other in radiation therapy. To be more specific, discussions are underway to organize a training workshop on advanced techniques in radiotherapy with practical hands-on training, and we are also preparing another IOMP school workshop on AI, artificial intelligence, and CT, computed tomography dosimetry, with also with practical training. So stay tuned. We sponsor and endorse events organized by our national member organizations and regional organizations. We have supported several events, training, education and training events lately. And we also accredit education and training programs and CPD courses, many of them on medical dosimetry, medical radiation protection, patient safety. And as you can see here, we have accredited many courses and programs. IOMP plays an important role in promoting safety, radiation safety, by promoting research in medical physics to improve radiation safety. We organize, as you probably, most of you know, we organize the ICMP and the World Congress. The international conference in Mumbai, India, last December attracted approximately 1,400 colleagues from 33 countries. We have already prepared the call for the next ICMP. You probably know that the next World Congress on medical physics and biomedical engineering is going to be organized, is going to be held in Adelaide, Australia, next year, 2025. Please save the date. Abstract submissions are scheduled to open in September 2025. Publications, you may be aware of the Medical Physics and Biomedical Engineering book series. This is the official book series of the IOMP, and we also publish the MPI journal, and we are planning to launch a new journal during the next months. Okay, now let's move to key areas of focus in ionizing radiation medical exposure. It's impossible to even briefly talk about those areas within the available time, but I can give you a few examples. I'll start from imaging in radiotherapy. Image-guided radiotherapy is a well-established approach. Radiotherapy patients are exposed to radiation during diagnosis, staging, planning, setup, follow-up. The cumulative dose is very high. This means that precise dosimetry for these patients really matters. Personalized dosimetry, we need patient-specific, equipment-specific, protocol-specific dosimetry to estimate patient organ doses and tissue doses. Using fandoms to estimate, for example, doses from computed tomography is not the best approach. This is, in my opinion, another key area of focus. And we should also become familiar with AI and do research using this tool. AI can significantly enhance patient radiation safety by optimizing, for example, treatment plans in radiotherapy. Moreover, machine learning powered models can accurately predict organ and tissue dose from imaging. Medical physicists should focus on this field. And this is another example, radiogenic risk appraisal, risk perception, and communication. Referring physicians and patients should be informed about doses, radiation doses, and especially about risks. How do we estimate those risks, and how do we communicate this information? Approximately 1.35 million people die each year globally from road traffic crashes. Road traffic injuries are the leading cause of death for children and young adults up to 29 years. The WHO provides detailed information about this on its website. If we divide by 365 the days of the year, that's around 3,700 people dying every day around the globe. To put that into perspective, this is like 20 aircrafts, each with 185 people on board, falling out of the sky and killing everyone every day. Nevertheless, the society, we are not so sensitive, in my opinion, to these accidents. Road crashes are common, they occur every day, making them a known risk that we all accept as part of our daily life. This has to do with the perception of risk. To communicate risks properly, radiogenic risks properly, we should take this parameter into account, into consideration. The risks from radiation exposure are long-term, they are statistical in nature, and the potential for developing cancer years after exposure is a less immediate, less visible threat, leading to different risk perceptions. I consider this topic to be a key area of focus for us, how to estimate risks, how to communicate them properly to referring physicians and patients. Importance of collecting data on radiation usage. This is obvious, I believe, very important, collecting data related to the frequency, distribution, and trends of radiation usage in medical diagnostics and treatment is vital for the reasons shown here: monitoring and assessment, identifying trends, minimizing unnecessary exposure, also for regulatory compliance. And this brings us to the next presentation, the UNSCEAR data and reports. In the interest of time, I'll stop here. Thank you for your attention. There will be a discussion session at the end. Please don't hesitate to ask questions using the Q&A Zoom tool. And now I will introduce our next speaker, Dr. Peter Thomas. We have uploaded his CV on our website, but I will read it again for you. So Dr. Peter Thomas is the director of the medical imaging section at the Australian Radiation Protection and Nuclear Safety Agency, ARPANSA. The section runs the Australian National Diagnostic Reference Level Service, provides educational material and advice, contributes to codes and safety guides, and promotes optimal use of medical radiation. Dr. Thomas served as the chair of the UNSCEAR Expert Group on Medical Exposures from 2019 to 2020, and was a main author for the 2020-2021 UNSCEAR report summarizing the global level of ionizing radiation exposures in medicine. Dr. Thomas was a member of the Australian delegation to UNSCEAR in 2005 and from 2019 to 2024. Dr. Thomas has a PhD in chemistry from Monash University and has worked at ARPANSA since 2000. So Peter, the stage is yours. Once again, please don't hesitate to ask questions. There is a Q&A tool down there. It is that the Zoom, as most of you know. So Peter, the stage is yours.
Thank you, John, and thank you, everyone. So as John said, my name is Peter Thomas. I'm the Director of the Medical Imaging Section at the Australian Radiation Protection and Nuclear Safety Agency and a member of Australia's UNSCEAR delegation, and I was on the expert group for compiling the recent UNSCEAR report on medical exposures, and I'm now a member of the committee's ad hoc working group on sources and exposures, and a bit more on that later. Before we start, I'd like to acknowledge that I am speaking to you today from the lands of the Wurundjeri people of the Kulin Nation. I pay my respect to them and to their culture and to elders past and present. And I also express my respect to First Nations peoples around the world, and in particular to any who are joining the webinar or watching this recording. So just as an outline, I'll talk a bit about UNSCEAR and its role, and then the main part will be a summary of the recent report on medical exposures, and then looking at some trends, the current actions that are being undertaken through UNSCEAR's ad hoc working group on sources and exposures, and something about future plans. So UNSCEAR. So the United Nations Scientific Committee on the Effects of Atomic Radiation, or UNSCEAR, was established by a resolution of the UN General Assembly in 1955. Its role and membership have been continued and extended by subsequent resolutions, and it currently includes scientists from 31 UN member states. UNSCEAR's primary role is to assess the levels, effects, and risks associated with ionizing radiation, and UNSCEAR disseminates its findings to the General Assembly and the scientific community and the public, and these include reports and scientific annexes and other publications such as public summaries. This slide shows the current member states included on the committee, and when UNSCEAR conducts its assessments, particularly of exposures such as medical exposure or occupational exposure and public exposure, the committee solicits data from all UN member states and liaises with many international organisations in the process at the same time. UNSCEAR's work started with the assessment of exposures to the population from atmospheric nuclear weapons testing, and then since then it's expanded into all facets of exposure to ionizing radiation. UNSCEAR has produced periodic reports on occupational, medical and public exposures, which seek to evaluate the level of exposure. Other UNSCEAR reports review information on the effects of ionizing radiation exposure on the human body and on the environment. And other reports review information on estimates of risk arising from exposures to ionizing radiation. UNSCEAR's work is part of the overall scientific understanding of the levels, effects and risks from ionizing radiation. And this scientific basis is the foundation of radiation protection policies and safety standards that are produced by other international bodies within the international radiation safety regime. Okay, so on to the recent report on medical exposures, which was approved by the committee in November 2020 and published in May 2022. So UNSCEAR has periodically produced reports evaluating medical exposures to ionising radiation. The general aim of these reports has been to make an evaluation of the global extent of medical exposures, and that is numbers of examinations, procedures or treatments, and the doses arising and the overall collective dose, and also the dose per caput. To do this, we need data from member states on frequencies of examinations, procedures and treatments per head of population that are representative of a country as a whole. And we need information on the dose per procedure. Generally, we're after an average dose along with an indication of the amount of variation, such as a standard deviation or an interquartile range. And I guess we also treat doses from therapeutic exposures somewhat differently in the report than doses from diagnostic procedures. John talked a bit before about why it would be a good idea to collect this information. And at this point, I'd like to outline what the committee, some of the benefits that the committee sees for member states to collect and compile data on frequencies of medical procedures using ionising radiation and the associated levels of radiation exposure, and to provide this data to UNSCEAR. So for a country itself, we think that helps your member state, your country, understand where resources are being spent, to potentially identify areas of need, for example, where there seems to be a low level of utilisation, perhaps indicating a low level of access, to prioritise monitoring and protection efforts to understand where the greatest levels of exposure are coming from and where there's the most potential for having a good impact in terms of protection activities, to guide research and training, and to assess the impact of national initiatives, so that if a certain change is made, for example, to increase focus on justification of procedures, to see whether the numbers of those types of procedures have changed as a result of those efforts. And then obviously to contribute that data to UNSCEAR means that that data can then be compared with other countries around the world. And so a country can see how their usage is comparing to other similar countries or to other countries who they would like to emulate, and also gain insights related to practice in other countries or regions. And that might also be useful for resource planning. So these are some of the things, the benefits that the committee sees in for states to collect this data in the first place, and then to contribute it to the committee as part of its work. Much of the work of producing an UNSCEAR report is performed by an expert group that's assembled for that specific task, and this slide lists the members of the expert group involved in the medical exposure report, and does note some other people who were important contributors. And in that connection, I'd particularly like to thank Farid Shanoun, who was and the rest of the UNSCEAR Secretariat for assisting and guiding and pushing to get the work completed. Farid has moved on to a position with the WHO, but still very much interested and involved. But the report itself was the collective work of a large group of people, and not least of those, maybe many of you on the call, on this webinar, who might have been involved at the local level in collecting data and providing information that eventually made its way into national contributions of data to UNSCEAR. So the overall objectives of the medical exposure report are to assess what is the global extent of exposure from medical uses. And in general, we find that medical exposures are the largest contributor to radiation exposure of the population from human actions. We are interested to know what the contribution of each of the different modalities of medical uses of ionizing radiation are to the overall exposure. We're interested in how the global extent of exposure and the contribution of each modality has changed over time, and how variable the use of radiation is between countries, and how variable doses are between and within countries. So the evaluation of medical exposures, like UNSCEAR's other compilations of which include occupational and public exposures, rely on three main sources of data. There's the peer-reviewed literature, there's data supplied to the UNSCEAR Global Survey, and then data that we might obtain through collaboration and cooperation with other international organisations that collect relevant data. Conducting the literature review was a major component of the work of the expert group, as also was reviewing and analysing the data submitted to the global survey. Okay, just a little bit about the survey itself. So there is an online survey platform that was accessible to what UNSCEAR calls national contact persons, and so they were the prime point of contact for member states to submit data to UNSCEAR. And then there were spreadsheet templates in three general categories: diagnostic and interventional radiology, nuclear medicine, including radioisotope therapy, and radiation therapy. Each template consisted of an introduction, an essential information, a tab on staff and devices, and a tab on frequencies of procedures or examinations or treatments, and a tab related to doses. So yeah, so here's the nuclear medicine one example here: an introduction, essential information, staff and devices, frequency and dose. Dose data was typically requested in terms of the relevant practical quantities, for example, entrant surface air coma or coma area product, CTDI, administered activity, and so forth, and so that the committee could apply consistent conversion factors to generate effective dose and not have to worry about different data contributors using different ways of deriving values of effective dose. This is just a short example of some of the elements of the spreadsheet. So the essential data consisted of summary totals of overall numbers of procedures in broad modality categories. You may not be able to see enough here, but this example from radiology has overall numbers of procedures in interventional radiology, computed tomography, dental, and then general radiography, not including these other components. And then summary numbers of radiologists and summary numbers of CT machines and X-ray machines. So these were simplified elements of data that were easier to collect and thus help to support the more detailed data that was provided by other countries. The detailed data included more detailed counts of professional groups and equipment, and detailed information on the numbers of different types of examinations, procedures and treatments, the age and sex distribution, and radiation dose information. And so you can see here for general radiography, we're talking about specific general procedure types, and so much more granular information. We also requested information on the level of uncertainty in the data and on the distribution of the data, for example, standard deviation or interquartile range in the dose information. The detailed data is, of course, what is ultimately required for a comprehensive assessment of medical exposures. However, the summary essential data was useful, particularly where collecting the more detailed data was difficult. It's better than no data at all, and provided a basis for estimating exposures where detailed data wasn't available. So just a little bit about the general categorization of medical exposures and particular modalities that UNSCEAR used. So overall, under medical exposure, we had diagnostic radiology, intervention radiology, nuclear medicine, and radiation therapy. Within diagnostic radiology, we had a separate look at computed tomography, and also amongst projection radiography, we looked at dental separately. And so in the end, these 7 general categories, conventional radiology comprising radiography and fluoroscopy generally with contrast media, and projection radiology generally without, as one group, dental radiology as another, computed tomography, interventional radiology, diagnostic nuclear medicine, radionuclide therapy, and radiation therapy. So these were the 7 broad modality categories that were summarised in the essential data, and that the broad part of the analysis covered. So ideally, we want to make an assessment of the overall level of exposure. Typically, we don't receive data from all member states. So to make a global assessment, we need to have a methodology for assessing or estimating the extent of exposures in member states for which we don't get data. For the most recent assessment, we had survey data from around 50 member states. The exact number varied across those 7 major modality groups, depending on what data was able to be supplied. That data was then supplemented with some of that essential overall summary data from other sources, such as other international organisations, such as IAEA. For example, their Imagine and NUMDAB and DIRAC databases contain information on equipment and staffing. The OECD has data for OECD countries, and the WHO Global Health Observatory has information, again, related to equipment and procedures. Now, previously, the overall global assessment in UNSCEAR assessments used a categorization of countries into healthcare levels based on the number of medical doctors per head of population. And so previous assessments looked at population-weighted averages of examination or procedure frequencies within those within the 4 healthcare level groupings to derive an average, a population-weighted average examination frequency in each of the 4 healthcare levels, and use that as the way of extrapolating to the global population. For this most recent assessment, we changed that approach and used some continuous modelling in order to fit to the survey data and use that result of that modelling to derive estimates for member states that didn't provide a response to the survey. So this next slide has an example. So this is for CT in this particular case. So here we have the frequency of examinations, in this case for computed tomography per 1,000 population here, plotted against the number of doctors per 1,000 population. And this background shading represents the healthcare levels. So more than one physician per 1,000 population is healthcare level 1. There's a group in here down to one physician per 3,000, which is healthcare level 2, and then healthcare level 3 and 4 in this yellow section here. So what's plotted here is the data on CT exam frequencies from all the member states that provided data as a function of this physician density. And what we did was fitted in this case, a power law model fitted in the absolute data space, so not using the log transformed data and fitting a straight line, but fitting the line in the absolute data space. And we then used the real data for those countries that submitted it, but for the other countries, we used the predictions from this trend line to infer a procedure frequency and thus contribute to the overall assessment. So we did these kind of models for each of the 7 broad modality categories. The nice thing about physician density is that the WHO collects that data and has it for essentially, there was only one member state for which we didn't have access to that data. So that means that we can fit a model and then use that to make predictions. We did look at other predictors, but generally with those more complex models, we didn't always have the data to be able to generate a prediction for the countries that didn't give us data. And so in the end, this relatively simple model seemed to have the advantage of simplicity and quite similar to the previous healthcare healthcare level method of extrapolation. And so that's how we settled on that model. But if you look at the UNSCEAR report, in particular Annex A, Appendix A, we discuss there some of the other examples and show some of the alternative predictions that were generated by other models. So here's the summary data for overall number of examinations, procedures and treatments for those 7 broad modality categories. So around 63% were conventional radiology, about a quarter were dental, about 10% computed tomography, and then 1% diagnostic nuclear medicine, and 0.6% interventional. Radionuclide and radiation therapy, we counted somewhat separately and are treated separately in the report. So in terms of then switching to dose per procedure, so again, we had, in this case, we had survey data from around 30 member states giving doses for the individual detailed procedures. And as I mentioned, we used the practical dose quantities as the base value, and then some reference conversion factors, which are all listed in the report. So you can see what was used and potentially modify that where there's better information on ways to convert from those practical quantities to effective dose. But then for those countries that didn't provide data, we had to again have a methodology for generating an estimate. And what we used in this case was we used the submitted data to calculate a frequency-weighted average dose per procedure within each of those within each of the five modality categories related to diagnostic imaging. So in radiation therapy, we didn't include the therapy doses in the analysis that we made of a collective dose. So we used those more detailed procedure frequencies to come up with a weighted dose within a given modality. And I'll show you an example shortly. There were two slight variations to that. We used an adjusted weighting scheme for radiology with a low mammography contribution for countries in healthcare levels 2, 3, and 4, where we were anticipating that there would be less use of mammography. That didn't actually make a great deal of difference in the end, because the weighted dose per procedure was still around about the same, just spread across different procedures. And then in nuclear medicine, we also used an adjusted weighting for where we excluded doses from positron emission tomography, where the WHO Global Health Observatory database didn't show any PET equipment for that particular country. And so that did make a bit of a difference in terms of the average dose per nuclear medicine procedure for those countries. So here's part of the example for CT. So down here we have the more detailed categories. So for each of these, of course, for the member states that submitted data, we'd have a number of procedures. And what we've got overall here is the overall relative frequency of those procedures averaged across all the member states that gave us data. So across all the 30 member states that provided data, CT heads for skull and facial bones were about 14% of all CT scans, soft tissue and brain are 16%, and so on. And then these are the average assessed effective doses for each of those procedures. And when you combine those together, we end up with an overall weighted dose per computed tomography examination of 6.4 millisieverts per procedure. So for the countries that didn't provide data, that's the dose value that went into the assessment. And so the overall result was an overall collective effective dose of 4.15 million person sieverts. Our assessed level of uncertainty is plus or minus 30%. That's at 2 standard deviations. And the great bulk of that came from CT, 62%, 23% from radiology, 8% from interventional, and 7% from nuclear medicine. And of course, we didn't include doses from the therapeutic, or didn't include therapeutic doses in this assessment of collective effective dose, given that those are doses, much larger doses designed to have direct effects. So the summary of the assessment was that medical exposures remain the largest contributor to radiation exposure of the population from artificial sources. We estimated 4.2 billion examinations per year worldwide, with an uncertainty of about 30%, and an annual collective effective dose of 4.2, rounding up from the 4.15 previously. And the estimated global annual effective dose of 0.57 millisieverts per head of population. So the estimate this time was derived from this continuous model, not extrapolation within healthcare level categories. And as we noted, computed tomography, about 62% of the collective effective dose, but only 10% of exams. And the interventional radiology is now estimated to account for about 8% of the collective effective dose, which is a bit of a jump from previously. We also looked at having made all those assessments for each individual country. We could look at where their rating of income levels in terms of the World Bank. So the World Bank has a four category system of high, upper middle, low, lower middle, and low. And so when you break down that overall assessment, perhaps unsurprisingly, you find that the high income countries have a greater proportion of all the procedures and the collective dose, and the average annual effective dose per caput in those high income countries is around 1.7 millisieverts per year. And in those upper middle and lower middle, we're down to 0.46, 0.31, and 0.13 in low income countries, but overall 0.57. So that's the basic outline of the report. So on to some trends and changes. This is an overall comparison against the previous assessment in 2008. There's a longer version of this in table 19 in the report, but this is just looking at the summary modality categories. So in general, we assessed a relatively similar number of general radiography procedures, but a lower dose. Dental procedures, we assessed a lot more, but this is quite an uncertain figure, and the overall collective dose is very low. Computer tomography is obviously the big component and has got bigger relative. Interventional radiology has also increased, and diagnostic nuclear medicine is also going up, but perhaps as a proportion fairly similar. So CT examinations were up 80% overall, and contribution to collective effective dose increased from 37 to 62. There was a major reduction in radiography and fluoroscopy examinations of the gastrointestinal tract and biliary and urinary systems. So that's a big reason why the conventional radiology exams are similar, but the collective dose as assessed collective dose has gone down. Interventional radiology now up to 8% compared to 1% in the previous assessment, despite only accounting for 0.6% of the total number of procedures. Nuclear medicine continues to account for around 1% of all procedures, and contribution to collective dose has risen from 5 to 7. And then for therapy, the number of treatments in radionuclide therapy was up 60%, and courses of radiation therapy up by 22%. This is an example of changes over time, which was part of the literature review that went into the report, and this chart appears in the report, and it's from a paper by Balanov et al. Looking at trends in doses in the Russian Federation. And I think this is also a great example, again, of what we were talking about at the beginning, of benefits to collecting this data, because without collecting data on procedures, you wouldn't be able to see these trends over time. And so these same trends as we were seeing in the overall report, this rise in computed tomography and fall in fluoroscopy, and a bit of a decline in radiography, and this now a notable component from interventional radiology. So this is a nice specific example. In terms of general trends across all the UNSCEAR reports, so the number of procedures is still going up. The frequency per head of population is perhaps not that different this time from last time. The annual collective effective dose has not increased this time compared to the previous one. And the average dose per person has gone down a little bit, although the overall uncertainty is about 30%. So this difference is within that uncertainty range. So just moving on now to some of the current actions of the committee. So as I mentioned earlier, the UNSCEAR's collection efforts focus on having a national contact person who serves as the conduit for data. And so the committee is continuing to aim to ensure that as many member states as possible have nominated a national contact person to facilitate data collection and submission, and also been encouraged to nominate additional alternate NCPs so that we can ensure some long-term continuity. We've been conducting webinars and assembling information to help NCPs in doing their role. And it's important to point out that we're not expecting NCPs to have all the information to respond to UNSCEAR surveys, but what we want them to be is a focal point for a network of data sources. And that's where the rest of you come in, because we really need you to be able to feed this information to the national contact person so that you can support them in getting the data they need and supplying it to UNSCEAR. UNSCEAR also has the ad hoc working group on sources and exposure, which I mentioned at the beginning that I'm a part of. So its main objective is to keep abreast of the developments in the exposure group types, to advise the scientific committee about if and when a new assessment might be considered in the program of work. And underneath that committee, we have small groups of experts evaluating the information that's available by screening the published literature, looking at reports and any documents that might have been submitted by national contact persons to the UNSCEAR Secretariat. So there's a small group of experts related to medical, another one related to occupational exposure, and there will be one for public exposure, but that hasn't formed yet because the public exposure report has only just been approved, and so the small group will be established this year. It's coming between now and the next UNSCEAR session, and so these are the people who are involved at the moment. And so the small group of experts has been monitoring the literature and has been involved in webinars to try and assist NCPs and give them information about how to fulfill their role and the type of data that we're looking for medical exposures in our particular case. So some of the things that we've been looking at in the literature that we've been reviewing is, well, CT has increased in the last, in this most recent assessment. Will this trend continue? Will there be increased uptake in some of these lower and middle income countries? We'd noted the growth of interventional procedures, and I think there's a clear need for better data to track. That's typically a harder and more complex type of procedures to track. So that's certainly an area where we need extra work to better understand what's happening there. We've seen a rising use of positron emission tomography. As we mentioned before, a bit of a decline in the use of radiography and fluoroscopy. And then in therapy, there have been evolutions in treatment techniques and in radionuclide therapy as well. Some recent increasing use of alpha emitters, for example. And here's two examples from what the small group of experts has been doing. So this is showing the trend of CT procedures in Australia. Technically, it's those claimed through the Medicare system, which is outpatient clinics and so forth, so not people admitted to hospitals, but you can see that the number of examinations by CT is continuing to rise. And so we would expect that overall usage to continue to be going up, and if that's repeated in other countries, that would continue to make CT a very strong component of the collective exposure. Here's another example of work looking at nuclear medicine procedures in Tamil Nadu in India. And a key thing here is the increasing proportion of positron emission tomography procedures, and making a much larger contribution to the collective effective dose. So those are just two examples of the sorts of things we've been looking at in the literature. So future plans. So the committee has provisional plans for a new evaluation of medical exposures to begin in 2026, but this will be somewhat subject to the resources available to the Secretariat and how progress with other work is being done, but that's on the provisional planning at the moment. The intention for the new survey would be to do it in 2 phases. And so with the first phase being this essential data, so those summary totals of equipment and staff, possibly summary totals of procedures, but maybe not. The intention really is to have a first phase that we hope is easier for countries to contribute, so that the national contact persons can get confident in getting data and developing a network, and then to follow that up with the more detailed data survey on procedure frequencies and doses. So the small group of experts and the ad hoc working group are currently reviewing the questionnaires used in the previous evaluation. We're seeking to strengthen the network of national contact persons and improve participation. And again, we're looking to collaborate with other international organisations that collect similar data or are interested in it. So how can you contribute? We're certainly looking to the medical physics community for help. Find out who your national contact person is. Maybe you know already. You can contact the UNSCEAR Secretariat to get help and say, hey, I'd like to help my national contact person. Can you tell me who it is? We're looking for physicists to help with national collaboration to get data on equipment, procedures and dose levels. Local data on examinations and procedure frequencies at your local hospital or clinic, or within a larger network is great data to be able to feed through to a national contact person to build to a national data set. And as I mentioned, we've got some particular areas of interest, for example, in interventional radiology, PET, changes in therapy techniques, and also imaging in radiotherapy. So just to finish, at its recent session, the committee highlighted the importance of reporting on medical, occupational and public exposure and the need for data from more member states in the future. And maintaining and extending the committee's network of national contact persons aims to ensure greater participation, which will enhance the quality, representativeness and reliability of the committee's evaluations. And collaboration with member states and international organisations has been and will continue to be essential. And with that, I'd like to thank you for your time.
Many thanks, Peter, for this excellent presentation. So it's time now for discussion. I think we have some time, not much time, but well, there are a few questions about involvement in UNSCEAR. How can somebody become a member of UNSCEAR? Does UNSCEAR have individual members?
So no, it's really up to the countries to nominate who they're. So there's only 31 countries who are members, who are on the committee, and then it's up to the government of those countries who they include on their delegation.
Yeah. So,
but there are other opportunities. So when expert groups are formed, there is the option. There are opportunities to look wider for people who would be members of expert groups to be able to assist in the production of reports.
How easy is the task of collecting data from countries? Do they have bodies that do those auditing? I'm asking because this is still a challenge in my country. So
yeah, so that's a very Yeah, and so I feel for you in Uganda, but I think many other countries are in a similar situation. So yes, there are some countries that would have national data collection activities, but many don't. And so this is really where, again, we'd be looking to the medical physics community, among others, but to assist whoever the national contact person is in providing them with data. So if you do have a national database, then that's great. Also, if within a given hospital group you have one of these, say, some dose monitoring software that allows you to aggregate information across procedures and doses, then that's useful information. But we also then need to follow that up with information that helps us extrapolate that particular local experience into a national figure. And so that's something that the national contact persons need help and assistance with.
There is another question about uncertainty. How do you calculate uncertainty?
So we used a very crude process, basically following normal kind of metrological ideas, where you have a number of procedures times dose equals collective dose, and you assign an uncertainty to each of those and just carry them through. So broadly speaking, we looked to countries to give some sort of assessment. So for example, in Australia, a lot of our numbers of procedures came from our Medicare database, which covers these procedures that the government pays for, which is not everything, but we estimate in our case is roughly there's about a 25% gap. So broadly speaking, we kind of assigned about a 20% uncertainty to our numbers. But if a detailed survey's been done, then that might be only 10%. But if it's a much more rougher extrapolation, then it's a much larger. And then obviously with doses, so in our case, where we were attributing dose to a country just based on the survey, we assigned a 50% uncertainty to those dose levels, and that's why the overall uncertainty came to that around about 30%. But it is a relatively crude estimate, and obviously with better information like a set of dose distributions, for example, we could undertake more detailed modelling of how those uncertainties feed in overall.
Sure. What correction factors, I guess the colleague means conversion coefficients, do you use to convert those metrics to effective doses?
Yeah, so the report itself gives all of that information. So I direct you to the report. In particular, we made, if I recall correctly, made quite a bit of use of the factors that were in the EU dose DataMed reports. So those ones, and of course, what would be interesting for the next assessment is the ICRP, for example, is in the process of producing. They've got one of their reports on conversion factors for radiological procedures that's currently on their publications, waiting for comment. So encourage anyone to have a look at the ICRP page and make a comment on their report. So I think in general, the committee or the expert group looked at published literature on conversion factors, and in a lot of cases assembled lots of them and picked a middle value or a common reference. And as I said, that EU dose DataMed was one of the key factors. But all of that's there, and there's the option of looking at that and saying, well, if the number was different, what would the effects be?
Yeah. There are a couple of questions about the website. Are these data available on your website? And there's another question. We can only help NCP if we know who they are. Is there a published list on UNSCEAR's website?
So at the moment, so the UNSCEAR website has the report. You can download the report from the UNSCEAR website, and there's also an Excel spread file that contains some of the summary data from the report. So it's not the exhaustive survey data, but it's versions of the tables that are in the report, but in an Excel format. In terms of national contact persons, at the moment, that's not publicly available. So that's treated with some level of security. And so at the moment, and also we don't want NCPs being barraged, but there is the mechanism of contacting the Secretariat. So if you are keen to find out who your NCP is, then please contact the Secretariat, and they can make inquiries and make sure that they're sort of controlling to some extent the traffic to the NCP. But at the moment, there's not. We are intending to have looking to have a sort of a new UNSCEAR platform that would enable NCPs to collaborate or with each other. So in other words, NCPs from different countries could talk to each other and, what are you doing in your country? How can I use that in mine? As a kind of help mechanism.
Thank you. There are many questions, so many, impossible to answer all of them. I will, another one, a couple of them about other modalities. So will the committee look at MRI systems, their increasing availability, impact on reducing computed tomography use? And another question about proton therapy. Any insight on RISE?
Yep. So again, the committee's evaluations are primarily aimed at ionizing radiation exposure. We didn't ask for MRI in our survey, and so that would be something for us to consider. But in general, we've tried to think, well, if we don't really need something, then we probably shouldn't ask for it, and we don't want to make it more complicated. That said, I think IAEA and WHO do include that information, so there is the potential to look at it from those collaborative lenses. And then, of course, we would still, in a medical exposure report, be conducting a survey of the literature. So if national groups made their own assessments nationally and published those in, for example, journals run by the IOMP or other, then UNSCEAR would look at all of that and include that in its summary reporting. And so again, if you go to the existing report and look at the appendices on each of those different modality categories, you'll see a discussion of the literature in the last 10 to 15 years in those areas. And radiotherapy, proton therapy. So yes, we're certainly looking at numbers of equipment and procedures, and in terms of rising use, numbers of treatments performed, that would be something to be looked at.
We are 5 minutes past. I think it's time to close. So Peter, many thanks for your excellent presentation. A lot of data, useful data for medical physicists and for healthcare personnel. Dear colleagues, ladies and gentlemen, many thanks for your active participation. Sorry for not being able to answer all questions, but we would need another webinar to discuss all these topics. Many thanks. Bye-bye.
Thank you.
Thank you. Bye.